Chapter 8, Eye Trauma. Now, when I went to ophthalmology, I had no idea how much eye trauma there is out there. Now, there are a ton of people out there doing dangerous things, hurting the eyes, and so I thought I would present this lecture of some of the common eye trauma I have seen and captured on video, and go through this on a case-by-case basis and explain some of the findings you're going to see and also how to approach these traumatic injuries. Now, there's a lot of things to see here, corneal abrasions all the way through retrobulbar hemorrhages, so I'm going to go through this fast and try to just hit the high-yield basics. So let's get going. The first topic, cornea abrasion. Cornea abrasion is definitely the most common eye trauma I see on a daily basis, and I see at least 1 or 2 patients a day in clinic with a cornea abrasion. So what is an abrasion? Well, if you think of the eye as covered by a very thin layer of the skin, really the entire body is covered with skin. It has to be that way. Bacteria and other organisms don't get into the body. Even the eye is covered by a very thin layer of epithelium. And if you remember, the cornea has 5 layers, and the surface layer is the epithelium. And if that epithelium gets rubbed off, you have a cornea abrasion. So, how do you diagnose it? Classically, we'll use a fluorescein dye and basically drop this dye into the eye and use a blue light to highlight that area, because when you rub the epithelium off, that raw surface will uptake that yellow dye, and it's a lot easier to see. Now, the drop method like this does not work that well, and the reason why is because if you get too much of that dye inside the eye, you end up getting so much it's really hard to tell if there's an abrasion or not, especially if you're not using a microscope. So the way I prefer to do it is using a fluorescein strip. This is a strip that has fluorescein dye impregnated on it. Add a little bit of a numbing drop and just use a little bit of it. You don't need much of this dye to pick up these corneal abrasions. So a little bit of dye, and here's an eye we think has an abrasion, a little bit of dye you can see in there. Turn that blue light on and it really glows, and you can see there's a scratch right here on the surface of the epithelium. Very painful. The eye has a lot of nerves in it, but fortunately the skin heals very quickly, but until it does, it's a potential nodus for infection. So how do I treat these things? Well, if it's really small, sometimes I don't bother with antibiotics, but I usually do some type of empiric erythromycin. If we have a contact lens wearer, you're more worried about Pseudomonas infection, so I'll use something like ciprofloxacin, or maybe even Vigamox. Sometimes we'll patch these eyes shut just because it seems to help a lot with pain. The problem with patching eyes shut is that bacteria like warm, dark places, so I don't really like to patch that often. Sometimes if you have a clean abrasion, doesn't look like it's that prone to infection, people will put a contact lens in, which acts like a bandage and makes the eye feel better and can promote healing. But I typically leave these eyes alone unless they're not healing well. Next topic, cornea laceration. This is a little bit deeper and more dangerous than the cornea abrasion. So this is an eye that's had a laceration. If we put our slit beam through here and look closely, you can really get a sense, the slit beam, that there is a line going right through the cornea. That slit beam lets you see that there's been a laceration all the way from the front of the cornea through to the back of the cornea here, and that is what we call a corneal laceration. And there's some other hints. This iris is kind of torn up here, so you know something got into the eye and probably hit the iris and hit the lens underneath. This is called the Seidel test. Very high yield, the Seidel test. Rub some fluorescein over that surface, and if you see clear fluid pooling out of that wound, then you know it's leaking. There's an active leak here. This is a Seidel positive corneal laceration. Not good, because if water's leaking out, your chamber can flatten, bacteria can get into the eye, cause bad infections, so Seidel positive is not good. So how do we treat a laceration? Well, in this case there was a laceration, but the chamber was pretty deep, so sometimes just putting a contact lens and seeing if it will seal up on its own can work. Other times we'll glue the area, but most of the time we do go straight to suturing, basically sew the thing up, because you can't have a leaking eyeball. You're set up for endophthalmitis. It's just not a good thing. Here's a little trick I learned back in residency. This is Dermabond. You can buy this at the drugstore, and I use a sterile drape and cut out a piece of plastic and almost use it like a patch. Put a little Dermabond on a piece of round plastic and basically stick it on like a plug in order to keep this leakage from getting worse. Other things we can use, of course, is cornea glue. I find this stuff really hard to work with, so I usually just go straight to suturing if a contact lens isn't doing it, but this glue is really hard to get into place. Next topic, metal foreign body. This is actually something very common as well that I see at least a few times a week. Usually a young man will come in who's been grinding metal, wearing safety glasses, but little pieces of metal get in his hair, then it falls into his eyes later. They come in, they have a little object on the surface of the cornea, and you can't leave those pieces of metal in there. You got to get them off because they'll rust. So I'm using a needle here. I like to use a big 18 gauge needle, something large, that way I don't accidentally poke through the cornea. It's a little bit safer, and basically get that piece of metal off. You can also use a Q-tip. Often a rust ring will be left behind, like you can see here, and you'd like to get that rust out if you can, because once again it's going to make it harder to heal. A nidus for infection. We use a little drilling tool, works a lot like a Dremel, to basically buzz that area, and this works really well for getting rust. Now there's no point in going crazy with this because sometimes you can do more damage than good if you're too aggressive, but if you can get as much rust as you can out, all the better. And treat this with antibiotics because you don't want that area to get infected while it's healing. Now if you have any case of metal in the eye and there's any concern for an intraocular metal foreign body, this is a big deal. So someone's doing metal on metal, hammering, and sharp pain, you don't see anything obvious, you really need to rule out some type of piece of metal inside the eye because metal will rust and it will kill off the retina because it's very toxic to the photoreceptors. So how do we rule out metal in the eye? Classically, they used to do x-rays. The problem is that radiologists aren't used to x-rays of the head anymore, just not that common. And so now pretty much the gold standard is CT of the orbit with thin cuts just to see if there's a metal foreign body in the eye. Next topic, chemical burns. Chemical burns is a unique entity. Basically you get bleach or something in the eye. It's one of the few ocular emergencies where you start your treatment before you even see the patient. So this is a chemical burn. I think this was bleach in the eye, and you can see that the cornea is very hazy. The conjunctiva is kind of white and has a bleached appearance. That's not good. When they have red eyes, that's a good sign. If the bleach or whatever burned it so bad that you actually have white or pallor to the conjunctiva, that means that those blood vessels have been cooked off, and that is not a good prognostic sign. So the first thing you need to do is irrigate these patients and check their pH and make sure it's normal. And the way you do that is we use pH paper. Basically put it in a cul-de-sac underneath the eyelids and up above. Make sure there's no foreign bodies under there, and make sure that the pH is normal. So how do you treat? Irrigate, irrigate, irrigate. A patient calls, says they have something in the eye. The first thing you tell them on the telephone is irrigate that eye 10-15 minutes and then come immediately to the office or the emergency room. Now if this happens to a kid who you can't irrigate, or they come into the ER, they'll often use what we call Morgan lens. So they'll numb the eye up with tetracaine, and then this Morgan lens actually attaches directly to an IV bag, and they can run several liters into the eye using these lenses. Now if you have a really bad chemical burn, sometimes corneal transplants will not work. And so this is actually a prosthetic cornea. That's a piece of plastic that's sewed in and locked into place with sutures, and it's always not a good long-term, well, it's the only long-term solution for these patients, but they had to use antibiotics and a contact lens for life. So anyway, chemical burns, nasty stuff. Base burns are worse than acid burns. Anyway, we'll move on. The subconjunctival hemorrhage. Now I see these quite a bit in clinic. They're often spontaneous. A patient will come in, their eyes extremely red, very worried, or sometimes after a fight. But the idea here is that there are blood vessels on the conjunctival skin of the eye, and if one of those little blood vessels ruptures or breaks for whatever reason, this is an extreme close-up. I've done some motion tracking so you can actually see the individual blood cells floating through those blood vessels. But if one of these blood vessels breaks, that blood seeps into the skin. If this happened anywhere else in the body, you'd just have a little pinpoint bruise, but because the conjunctival skin is so lax on the surface of the eye, it tends to seep under the eye and is very impressive. Now, conjunctival hemorrhages are almost always completely harmless. The one thing you watch out for is something called a Delin. Sometimes if the conjunctiva gets so swollen from that blood under there, that hematoma, then you'll get a little area of dryness here on the cornea. The idea here is that the cornea dries out because it's lubricated when the eyelid comes down and covers the eye. If the eyelid is coming down like a windshield wiper and there's a bump, then sometimes you'll get a little area that doesn't get adequately covered with tears, and that little area will dry out. It forms a Delin, and when the cornea dries, it thins and could, in theory, perforate. So if a patient's having any discomfort, any blurry vision, really bad conjunctival hemorrhage, will watch this. This was treated with erythromycin ointment to lubricate the eye, and within a day, they were 100% better. So a Delin. Traumatic iritis. An iritis just means an inflammation in the eye. Let's say you have a young patient come in, was in a bar fight or got hit in the eye, and their eye hurts, and they have a lot of sensitivity to light. You think maybe they have a corneal abrasion, but they don't, under fluorescein, and yet when you look at the eye, it just looks like it's very irritated. So what is the iris? If you have an iritis, that's an inflammation of the iris, right? Well, the iris, we know, is the colored part of the eye, and is part of the uvea. And uvea is sort of a catch-all phrase, let me go back, for a combination of the iris, the ciliary body, and then the choroid in the back. Those three structures make up the uvea. And when you hear about people having uveitis, that just means an inflammation of one of these layers. When we say iritis, that's a little bit more specific. It tends to imply more inflammation in the front part of the eye, specifically of the iris, and these patients have iris inflammation. And because the iris is a muscle, it contracts, constricts, and dilates depending on light, and that muscle is hurting, then they have sensitivity to light, or what we call photophobia. So how do we diagnose it? The first thing we notice is we look for inflammation in the eye, and we look for what we call cell and flare in the anterior chamber. So when you look at the anterior chamber, that potential space full of water in the front part of the eye, we look for cell, which is individual inflammatory cells floating there, and flare, which is sort of a smoky protein that we see from leaky blood vessels. And here's a video that's going to show what I'm looking at. So we're looking at an eye, make our slit beam nice and short, bright, and kind of wide, and you can see individual blood cells, or white blood cells floating in here, macrophages, etc. That's cell, and that sort of smoky appearance to the entire area is what we call flare. So a lot of inflammation inside this eye. It's hard to learn to see cell and flare, but once you work with the slit lamp a while and see enough of these patients, it's going to be secondhand. So how do we treat iritis? Well, we treat it with two things mainly. Steroids. Steroids are good for cooling things down. It's anti-inflammatory. So Pred Forte. And cycloplegia. Basically, you dilate the eyes for comfort. The idea here is that if the iris is inflamed and hurting, it spasms when you're around bright lights. By dilating the eye, you kind of paralyze the ciliary body and iris, and by paralyzing them, they don't hurt as much with bright lights. The other thing you watch for is pressure, because if you have a lot of inflammation in the eye, that can clog up the trabecular meshwork and cause issues. But really, steroids and cycloplegia are the two main things I treat. Hyphema. Hyphema is just a phrase that describes blood inside the eye. This is a traumatic injury where there's been bleeding in the front part of the eye so much that that blood has actually layered out into what we call a hyphema, a layer of blood in the anterior chamber. So, not all that common, but we do see it, and it can be an issue. And the way we treat a hyphema is very similar to iritis, in the sense that we treat with steroids. Steroids cool things down, that's what you want in the eye. Cycloplegia, so that basically paralyzes the iris and the ciliary body, and makes the patient feel better. But another good thing is that cycloplegia, by dilating the eye a little bit, keeps the iris from getting sticky, because when the iris is inflamed, it wants to stick to things, and you don't want it sticking to the lens underneath, because you'll end up getting iris synechia, and your patient will end up not having a round pupil. They'll end up having a keyhole pupil, or their pupil may look like a cat's eye, and so cycloplegia is important in these cases. Now the big thing to watch for with hyphema is pressure, because all that blood in the anterior chamber will clog up the trabecular meshwork and cause pressure issues, and that is a big deal, especially in these patients. That's especially important to watch around days 3 to 5, because usually there'll be some type of microscopic clot at the level of the iris that keeps it from bleeding anymore, but that clot will start breaking down around days 3 to 5, and you can sometimes have a rebleed. And so we check the pressure in these patients very closely, especially if there's a lot of blood. So what happens if you have a patient who has very high pressure? Well, you hit them with lots of eye drops in an attempt to decrease it, but often it's not enough. Sometimes they have such bad bleeding, we'll have to do a paracentesis. This obviously is not a great treatment, just because the AC fills up with aqueous so quickly, but I'm basically creating a paracentesis at the slit lamp so I can drain off some of the excess fluid in an attempt to get this pressure down. And I'm going to burp this wound. This is called burping. We do this sometimes with our cataract patients the day after surgery if their pressure is too high, but I'm basically pushing on the posterior edge of this wound. And in fact, if we use a little fluorescein, we can kind of do a Seidel test, kind of like before, and you can actually see that fluid coming out. So let's sort of a self-made Seidel test. Let's try this. So I'm pushing on it, and you can see that fluid burping out and see if the pressure comes down. So high FEMA. Sometimes we'll go in and wash that blood out, doing an AC washout, but that can sometimes cause rebleeding. Here I am checking the pressure. The pressure has come down quite a bit, as you can see from our Myers here. So one important point here with high FEMAs is you have to be careful with certain medications. And that medication is the carbonic anhydrase inhibitors, such as Diamox, and in our case we use some of the pressure drops are also CAIs, such as dorzalamide. And the reason is this: if you have a patient who has sickle cell or some type of sickle cell trait, then their blood cells have a tendency to sickle. If their blood cells sickle in the anterior chamber, then they're going to clog up the trabecular meshwork very quickly and cause big problems. One of the things that Diamox does is it causes a metabolic acidosis. It makes things more acidic. Well, the same thing happens with the same class of medications. If we use an eye drop, such as Trusopt, Azopt, these things that are CAIs, they will make the anterior chamber more acidic. If there's blood here, they'll immediately sickle and cause a big problem. So any patient who you have a suspicion might have sickle cell, go ahead and do a sickle prep before even considering using these pressure drops. So, important point. Next topic, the wall fracture. We see a lot of orbital floor fractures and medial floor wall fractures, usually called in from the emergency room or inpatients. But the thing to realize about the head, and the face in particular, is that our skull is developed in many ways like a crash test dummy. It's designed to crumple under a high impact. In many ways, kind of like a car, the front of the car body is designed to crumple slowly in order to save the important occupants of the vehicle, which is you. Well, the same thing with the head. There are sinuses, and those sinuses are designed to crumple to protect the eyeball and the brain from violent impacts. So, if we look at the eye, it sits inside the eye socket. The eye socket has a lot of little bones that are right next to a bunch of sinuses and are designed to crumple. In fact, if we look at a CT scan and look at the eye here in the orbit, you can see that the eye sits here. There is a floor that can crumple down into the maxillary sinus, and then there is the medial wall, which can crumple into the ethmoid area. Now, this ethmoidal bone here is called the lamina propria, which just means paper-thin wall, because this is actually the thinnest wall of the orbit. This is where it is the thinnest. And yet, despite that, it's actually the floor that tends to break more often, because this area has ethmoid air cells. There's a lot of buttressing. It doesn't crack that often, but this floor, man, this thing goes out all the time. So the vast majority of wall fractures are floor fractures. Yeah, let's move forward in our CAT scan. There we go. So what do you look for when you have a potential floor fracture? Well, you want to see if the eyes are in good alignment, if the patient's having double vision. So check their extraocular movements in all gaze directions. I'm checking cross-cover testing here for tropias and phorias, just to make sure everything's okay. A lot of these patients will have double vision just because of swelling, but not because of any major issues. Check sensation, especially V2, because the V2 nerve runs along the floor of the orbit and is also out, so check it out. Check for step-off fractures, basically around the rim, see if there's any breaks. Look for enophthalmos. Is the eye sunken in? And if you look from below or above, you can sometimes tell if the eye is sunken in or out. This is a Hertel test, and a Hertel basically measures how far out the eyes are sticking, and is another way to see if the eye is sunken in. And why are we checking that? Because the big question with any wall fracture is there entrapment? Is the muscle that attaches to the eye stuck inside that bone? Because as that bone breaks, it often acts like a trap door and will entrap that muscle. This is especially true with the, this is the medial rectus here, but the floor is most often what gets entrapped. And so the big question is there entrapment? The ENT guys and the facial guys, they're always asking us that because they want to know, do we need to take this guy to surgery to try to reconstruct that floor. So how do you check? Well, this is a forced duction testing. I'm using a Q-tip here on a numb eye just to see if the eye will get up. Is it tethered? Is the eye stuck? The Q-tip doesn't work that well though, because especially on an awake patient, because they're going to resist you. I mean, who likes your eye getting pushed around with a Q-tip? Really, the more exact way is to do forced duction testing using forceps and actually grabbing the eye at the limbus and yanking and seeing if it's stuck or not. Very hard to do in an awake patient. This is obviously during a surgical case, so it's a little bit easier. So, forced ductions. Next topic, lid lacerations. So, the eyelid can get lacerated, and we're usually called in when the laceration involves a medial margin. Now, even though this laceration here looks bigger, it's this little laceration here next to the nose over here that's more concerning. And the reason why is because that little hole there, that is the punctum. That's the tear drainage pathway from the eyes into the nose, and this laceration goes right through the canalicular system, and so this little laceration is much more worrisome than that bigger one. And if we review our anatomy, remember that tears are produced, they cover the eye, they form a lake in the bottom of the eye, they drain through the punctum, through the canalicular system, into the lacrimal sac, down the nasolacrimal duct, into the nose, and that explains why if you have runny eyes, you often have a runny nose. And if you get a laceration medially here, through that system, when that heals, that may scar, and this patient may have tearing or epiphora for the rest of their life. And so if you see this, you try to pick it up and repair it at the initial insult. This is how I repair most lid lesions. Remember that the eyelid has two lamellas, two layers. And you can think of it as a front layer, which is basically skin and orbicularis muscle, and the back layer, which is the tarsal plate, which is that sort of collagenous fibrous layer that actually gives the eyelid some shape. And so when you repair it, I like to repair both layers. And to do that, I'll usually do a silk suture at the margin. That way I can get the lashes to line up, and throw some burieds and a couple of superficial. Here, I'll show you a video. That'll make more sense. So what I've done here is I've used two silk sutures through the posterior, through the tarsal plate, and one a little bit further forward in the anterior and the orbicularis muscles to approximate things. Put lots of stitches in. I don't put any on the inside surface of the lid because you don't want that rubbing on the eye. And here, I've repaired that canalicular lesion, but see this right here? This is what we call a monocanalicular stent. It's basically a silicone tube running from here through the canalicular system into the sac and slightly down the nasolacrimal duct towards the nose. And by leaving this piece of plastic in there for 3 or 4 months, that will allow things to heal around it and keep that pathway patent, and then eventually this gets yanked out, and hopefully the nasolacrimal system is intact, and so they won't have epiphora. Now, along those lines, the next topic is lid avulsion. Let's say you have a really bad lid laceration. In fact, the lid is practically ripped off. In this case, the punctum of this eyelid right here, that's the lower eyelid here, the punctum that's supposed to drain over here is way over here. Let's see if I point it out. So somewhere in there is the nasolacrimal sac, and the punctum is right there. Hard to see it, that little guy right there. And that needs to somehow connect up with that in order to drain into the nose. My little monocanalicular stent is probably not long enough to do that successfully. Of course, the eye is intact here. And so in these more complicated cases, we'll do something called a Crawford tube. And a Crawford tube is basically a big long silicone tube like an angel hair pasta attached to 2 metal probes. And we basically run those probes through the canalicular system into the nose, and then we run out through the lower eyelid, out the punctum, into the punctum of the upper eyelid, back into the system, and basically you make a big loop. And so you'll see what that loop looks like in a second. This is the same patient. I've sewn the eyelid back into place a few days later. He's looking great, though a lot of swelling, of course. But if we open the eye up and zoom in, that's that canalicular tube right there. That little tube, it's a little blurry, I know, but basically it's going from the nose up through the canalicular system, out the punctum, back into the punctum, through the area where it was lacerated, back into the nose, and it's tied off back there. And that little loop stays there for 3, 4, or 5 months, and eventually we yank the cord, and hopefully things stay patent. So, Crawford tube. Big topic, open globe. This is the big nightmare we're always worried about, and they usually come in around 2 in the morning. But the open globe is when you have an injury that perforates the eye, where the contents of the eye is exposed to the air, and they need to be repaired, and the end result's always terrible. Now, the number one rule with open globes is if you suspect an eye being open, do not push it. I was lucky here. That eye was intact, and this patient did fine. But the last thing you want to do with an eye that you're not sure if it's open or not, because it's a bad injury, is push on it, because you can very easily squeeze the contents of the eye out onto the cheek. And so you need to take these patients to anesthesia, put them under general, and explore the eye, because you could have a laceration or a perforation into the eye. And the two places where the eye seems to break the most is along the limbus. That's where it's thin. The white part of the eye hits the colored part of the eye. And under the rectus muscles, where these muscles attach. That's a very complicated place to have a perforation because it's really thin here. Like most of the sclera of the eyeball is about 1 millimeter thick. Well, the sclera is only about 1/3 of a millimeter thick right at this muscle insertion. And so that's where it will perforate, which really sucks because if you're trying to sew that up, it's underneath the muscle. You have to disinsert the muscle, sew it up, try to reinsert the muscle, and see what happens. These patients almost universally do very poorly, but I've been surprised. You sew it up and see how they do, admit them, IV antibiotics, and look for retinal detachments. Retrobulbar hemorrhage. This is one of the few eye emergencies, and basically this is a hemorrhage behind the eye. If you think of the eye kind of like a scoop of ice cream inside the eye socket, and the rectus muscles attached back here at the annulus of Zinn and attached to the eye, there's actually a tissue that connects all those rectus muscles almost like a cone. It's a potential space, basically. It's the retrobulbar space. And in fact, when we do certain types of anesthesia for big surgeries, we will inject anesthesia directly into this potential space. The problem is if you have an injury to the eye so bad that there's actually active bleeding back here, that can quickly cause a pressure increase. And if the pressure is too high in the eye, say 50, 60, 70, for too long a time, there will be permanent optic nerve damage and they lose the eye. So what do? Well, the reason that the pressure goes so high is it's like a compartment syndrome, and there's eyelid swelling, and the eyelids won't let the eye protrude forwards, and so we have to do a lateral canthotomy, cantholysis, and basically cut the insertion of the lower eyelid off of the bone here. That way the eye can protrude forward and potentially save the eye. So you're cosmetically messing up the eyelid, but what's the point of having an eye if it can't see? And so this is a vision-saving procedure. If you have a case where a patient comes in, they've been hit in the eye, their pressure is 70, 80, and you think there's a retrobulbar hemorrhage, and cut the eyelid off to save the eye. So we just covered a bunch of material. I mean, that was a lot of stuff, a lot of videos. I'm sorry some of those were gory, but I think that by seeing these things, it's going to make it a little bit easier to recognize them, and hopefully my take on how to approach these things will be useful as well. And thanks for watching. I appreciate it.